Welcome everybody to our lunch and learn today. I'm just going to start with a karakia. Whakatakata hou ki te uru, whakatakata hou ki te tonga, kia mā kina kina ki uta, kia mā taratara ki tai, e hi aki ana te atakura, hei tio, hei huka, hei ho hu, ti hei Māori ora. Welcome everybody to today's lunch and learn. Just a quick little recap before we start. So this Lunch and Learn is brought to you care of the Paediatric Society of New Zealand. It's an organisation of health professionals working together to progress the health and wellbeing of children in tamariki and young people or rangatahi throughout Aotearoa, New Zealand. The Paediatric Society is a place for an opportunity to engage with other professionals with similar interests, and it supports the New Zealand Child and Youth Health Clinical Network, which today is where we are presenting the Lunch and Learn from. Also, it does offer assistance for education grants to all members via an application. So check out that website at the bottom, come along and join us, see if there's an interest group that interests you. So today's session is the guest speaker is me, and today's session is called Parent Carer Trauma Insight for Clinicians. So I am a paediatric physio. I'm the clinical leader of physio in the Child, Women and Family Division in Te Whatu Ora, Waitemata. I completed my master's exploring caregivers' experience of implementing sleep systems for children with complex neurodisability. And this Parent Carer Trauma presentation that I'm giving you is because of my ongoing journey following on from the Masters about exploring the burden of care that parents shoulder. I have no expertise in relation to providing trauma-informed care, but I am sharing key insights and practical tips from attendance at Parent Carer Trauma Masterclass. So throughout the talk, if you can maybe think about your workplace and what services or processes do you think contribute to ongoing small t trauma for parents, and maybe think about what changes you could make to reduce unnecessary service trauma. So I'd like to acknowledge Born at the Right Time, Rachel Wright. So just to be clear, I'm not an expert in trauma-informed care, and there are many professionals and organisations specifically focused on and skilled in this area. However, I am passionate about supporting and working alongside parent carers of children with complex disability, and I hope that this short presentation on insights from a novice, inexpert, but curious clinician helps increase understanding of parent carer trauma, how we may inadvertently be increasing trauma, and will, I hope, offer some suggestions of how we can work to reduce trauma and improve parent carer wellbeing. So how did I become interested in parent carer trauma? I've already said about my masters, but as a paediatric physio, I support children with complex disability and their whānau, in particular with lying and nighttime positioning and postural care equipment. This is challenging work for both therapists and families, and this equipment is often abandoned. And I wanted to understand why, so I undertook a master's study exploring caregivers' experience of implementing sleep systems. Caregivers spoke about the complexity and burden of their child's nighttime cares, limited knowledge and support to address their priorities of sleep and comfort, and embedding principles of family-centred care, prioritising their goals and fostering hope and trust through partnership were identified as critical components of care. Following this study, I undertook a quality improvement project together with families to explore what future care would look like. And I kept wondering why parents didn't feel supported. What were we missing? In both the Masters and Quality Improvement study, parents spoke of feelings of grief and fear, being exhausted, feeling alone and unsupported, and being angry and always having to fight for or advocate for their child. I think we believe we are working in a family-centred care way, but parents' stories left me feeling perhaps we weren't. So what are we missing? So I've been on a journey of exploration to try and fill this gap in my understanding and skill. And this course, Masterclass in Parent Carer Trauma, for practitioners has been really helpful for me in what I think is part of the gap or missing piece, recognising, understanding, supporting and working to minimise parent-carer trauma in our care. Born at the Right Time was established in 2015 by founder Rachel Wright, and their work focuses on bridging the gap between families and practitioners through the power of lived experience. They offer consultancy, advocacy, and training with these courses listed on their website, and I can highly recommend them all. And here's another plug for Born at the Right Time. If you're a clinician and you can't afford a course, but you want to increase your understanding and awareness of the perspectives of parents and caregivers of children with complex needs, then this podcast, The Skies We're Under, is a fantastic free way to listen, learn, and have your medical, clinical, therapeutic, and professional thinking challenged. It's a podcast by and for parents of people with disabilities and the many practitioners who support them. As well as helping practitioners, I highly recommend that you share this with the parents and families you may work with, as it's a way for parents who often feel so alone to feel connected and seen. Sarah Clayton and Rachel interviewed me to discuss my master's research, and if you're interested, I'm back on season 2, episode 8, A Complex Night. They've had a whole series on trauma in season 4, and Amy Hogan, a New Zealand researcher, advocate, and person with lived experience, who has presented here for us in the Lunch and Learn, is interviewed on season 4, episodes 40 and 41. And Aurora Hamill and Lucy Charles, New Zealand OTs who developed the F Words Life Wheel, are on season 4, episode 10. I also want to quickly share this UK-based website specifically focused on providing emotional support for parent carers, which you may want to explore or share with the families that you work with. Parent carers provide sustained, intensive, and often unrelenting care for children and adults with disabilities. The heavy demands they carry can take a serious toll on their mental and physical health. Yet the focus on all those around them is often solely on the child. Studies have identified that parent carers can be at risk of poorer physical health, such as cardiovascular issues, weakened immune systems, and increased illness, increased morbidity, and shorter life expectancy than other parents. They have significantly higher levels of psychological concerns, such as stress, anxiety, distress, anger, depression, feelings of entrapment within their caring role, leading to higher incidence of suicidal thoughts and attempts. Other difficult emotions such as guilt, shame, helplessness and hopelessness, a sense of loss, envy of other families, and chronic exhaustion are common. This can be due to many factors, including coming to terms with their situation, navigating the complex systems around them, education, health, and social care, which are intended to support them, but can unfortunately add to the parental burden. Lack of sleep, experiencing blame or not being believed, as well as stigma and discrimination. This discussion paper on the Affinity Hub website provides robust information and evidence on parent-carer trauma. Trauma is a universal human experience, but how it is experienced, processed, and expressed can vary a lot depending on the context, role, and environment. There is no single definition of trauma, but there are some common elements. This internationally recognised definition of trauma is developed by the Substance Abuse and Mental Health Services Administration, where trauma results from an event, series of events, or set of circumstances that is experienced by an individual as harmful or life-threatening. While unique to the individual, generally the experience of trauma can cause lasting adverse effects, limiting the ability to function and achieve mental, physical, social, emotional, or spiritual well-being. And you can see what I've highlighted with the emphasis on the 3 E's. Post-traumatic stress is a common response to a traumatic event, and it only becomes post-traumatic stress disorder when the symptoms are severe and persistent for longer than a month and negatively interferes with a person's ability to function. Some suggest that complex PTSD might be a more relevant definition for parent carers, which defines it as exposure to prolonged or repetitive trauma from which escape is difficult, like domestic violence or captivity. For parent carers, trauma is rarely just a single dramatic event. Instead, it is often chronic, cumulative, and embedded in everyday life. Post, present, and predicted for the future PTSD has also been posed as a more accurate definition of trauma for parent carers because parent carer trauma can't always be described as post. Vicarious trauma describes the emotional impact and psychological distress of repeated witness, exposure to, or participation in the traumatic experiences of others. For parent carers, these might be holding a child for a blood test, witnessing ableist slurs, seeing the impact of insufficient support on their child's development or mental health. But it is also particularly relevant to professionals who, through repeated empathetic engagement with trauma survivors, absorb emotional distress over time. This is highly relevant for those working with parent carers of disabled children. Big and small T trauma. Research suggests that many parent carers experience trauma as both major events, big T, and small, cumulative, and ongoing traumas, small t. Examples include birth trauma, receiving child's diagnosis, witnessing invasive medical procedures on the child, illness, disabilities that involve waiting for the next episode, such as epilepsy or severe allergies, where justified hypervigilance is justified. Child behaviours described as challenging, for example, child-to-parent violence, life-threatening, life-limiting illnesses or conditions and high-risk medical procedures, being declined for specialist school, therapies or support which are viewed as vital for the child, being told that their child will never walk, talk or be independent, extended waiting times, having to repeat difficult histories, challenging conversations with professionals, an implementation gap between what is promised and what is delivered, being blamed by wider family or society for the child's behaviours or diagnosis, for example, autism when it's not recognised in some families, recognition that their child might not reach independence, secondary trauma of abuse of the child in an institution, microaggressions due to ableism, like the do not resuscitate orders placed on disabled people during COVID-19, or discrimination. Disabled people and their families are disproportionately affected by austerity and the cost of living crisis, and fighting to access support with repeated exposure to scrutiny from practitioners, a fear of being blamed, and the threat of losing services, and the paradox of having to remain or re-engage with the very services and systems that caused harm or trauma just to ensure their child's needs are met. A key aspect of the small t trauma is that there can be little time in between to process them and move on before the next one comes along. It can be difficult to distinguish between some forms of chronic stress and trauma. Behaviours that might be described as dysregulated or hypervigilant in the general population may in fact be life-preserving for parent carers as they navigate a complex system of care, all while attempting to prevent a deterioration in the health of their child. Awareness of these big and small t traumas highlights the importance of seeing parental behaviours through a trauma-informed lens rather than pathologizing. So what might we see? The 5 F's describe common unconscious survival responses the nervous system may activate in response to perceived threat or trauma. Alongside the traditional fight or flight theory, research has expanded to include other responses, especially relevant for complex or chronic trauma, such as that experienced by many parent carers. Fight. responding with aggression, control, or confrontation to regain power or to stop perceived harm. Flight, avoidance, restlessness, or overactivity in an attempt to escape the situation or emotions. Freeze, immobility or dissociation. The body shuts down or becomes numb when neither flight or fight are viable. Fawn, people-pleasing or appeasing behaviours to avoid conflict or danger, often learned in environments where asserting needs was unsafe. And flop describes collapse, exhaustion, or submission when all other responses are depleted. Common signs of trauma in parent carers are emotional distress, hypervigilance, heightened anxiety or worry, irritability or anger, withdrawal or reduced social interaction, avoidance of services to protect themselves from further trauma, chronic sorrow and grief, the natural ongoing response to an irremovable loss. For parent carers, this may result from unmet expectations and repeated losses, such as seeing other children reaching culturally celebrated milestones, like the first day of school, doing exams, driving, going flatting, forming romantic relationships, and feelings of powerlessness. Parent carers cannot step away from their role and have to navigate systems where power is held by professionals, often creating a sense of powerlessness, isolation, and ongoing strain. And trauma doesn't exist in isolation. It's shared and relational. Parents are affected by their child's trauma, and children are affected by the emotional and psychological responses of their parent carers. And professionals can be impacted by the interactions with traumatized families, especially when trauma remains unrecognized or unaddressed. When professionals work with trauma responsive structures, when professionals work without trauma responsive structures, they may experience compassion fatigue, burnout, emotional detachment, or defensive practice. This in turn affects service delivery, team morale, and relationships with families, further perpetuating the trauma cycle. Unacknowledged trauma undermines communication, trust, and the safety of disabled and medically complex children. Professionals work hard every day to support disabled children and their families and do not intentionally cause harm. But we need to ask ourselves if we are offering meaningful support or adding to their burden. Systems-generated trauma refers to the trauma caused not by the original event or condition, but by the actions or inactions of the very systems meant to support them. Some examples parent carers may experience include they seek help and are met with suspicion. They are repeatedly asked to provide the same information, to justify their needs, or to relive distressing histories. Multiple professionals micro-scrutinize or micro-challenge their decisions. They might seem small, but cumulatively they become overwhelming. They feel pressured to advance, to advocate fiercely, to get basic support, despite being dependent on the very systems that are dismissing them. The impact of systems-generated trauma can be deep and long-lasting. Loss of trust in professionals and systems, which can impair collaborative working. Avoidance of services, even when support is vital for the child's health or education. Heightened states such as hypervigilance, distrust, and burnout, and the ongoing emotional tightrope of being utterly reliant on services while constantly needing to advocate, question, and push back. Trauma-informed practice or care is influenced by neuroscience, psychology, social science, and attachment and trauma theories. Trauma-informed practice is an approach that recognizes the presence and impact of trauma. It is not about fixing trauma, but about working in ways that reduce harm, build trust, and supports everyone. A trauma-informed approach is a whole system organisational response with commitment from both individual workers and organisations needed for it to be successful. In the context of parent carers, trauma-informed practice means understanding the chronic stress and trauma they may carry and making adjustments to avoid re-traumatizing. The 6 principles of trauma-informed practice are safety, trust and transparency, empowerment and voice, collaboration, cultural consideration, and recognition of trauma. This image is taken from Tupo, the National Workforce Centre for Addiction and Mental Health in Aotearoa, New Zealand, and has fantastic resources on trauma-informed practice in the Aotearoa, New Zealand context. I don't have the training, skill, or expertise to advise within this short presentation, but a crucial starting point is for services to take care not to traumatise and re-traumatise parents and families. Trauma-informed care is everyone's responsibility, and whilst it's crucial to build the knowledge and skill of individual workers, a trauma-informed approach won't be successful unless organisations and services also commit to a trauma-informed approach. One of the questions at the end for you to take away and consider before the next knowledge translation session is to think about what service processes in your workplace contribute to the ongoing small t trauma for parents. And what changes could you make or advocate for to reduce unnecessary service trauma? Trauma is more common than we think, and parent carers are at increased risk of trauma due to the constant emotional, physical, and systemic demands on their role. So what can we do? Psychological first aid is a key tool for practitioners who don't diagnose or treat those with trauma or mental health. It's a compassionate approach to supporting parent carers who may be experiencing crisis, trauma, or overwhelm. With principles of a sense of safety, calm, building a sense of self and community efficacy, connectedness, and hope. This Empathy in Practice guide from the CoLab Partnership Group is a great resource with practical things you can do and say every day in your work alongside parent carers. I haven't time to go over all the suggestions here, but you can download it from their website and maybe put it up in your workspace. Share it with colleagues and managers. Try and implement some of the suggestions with the parent carers you work with and bring back your observations and experiences to our knowledge translation session next month. And here's a list of some do's and don'ts. We're running out of time here, so maybe these might also be things to think about later. Discuss them with others, try some of the do's, and try and stop doing some of the don'ts. What worked? What didn't work? And bring your experience back to our knowledge translation session next month to discuss. But if I could emphasize one thing, it would be curious and not judgmental, and always assume trauma may be present. So I just want to finish by circling back to my original dilemma. Embedding principles of family-centred care was identified as critical in my master's study. And in Aotearoa, New Zealand, family-centred care is widely accepted as the foundation of good paediatric care, with the underlying principles centering on the child as an individual and central to the family, dignity and respect, communication and information sharing, participation, collaboration, and access and care coordination. But we live in Aotearoa, New Zealand, with our history of colonisation and significant health inequity. So does family-centred care alone really address our New Zealand context? Maybe we need to integrate Māori-centred models, such as those recommended by Wilson et al., that include dimensions of health and well-being, wairua, whānau, hinengaro, and tinana, whanaungatanga, connectedness, whakawhanaungatanga, building relationships, and the socio-political health context in Aotearoa of colonisation, migration, racism and marginalisation. But given what we know about parent-carer trauma, I think it's critical we also integrate trauma-informed care. This diagram illustrates the potential for trauma-informed care to be used in conjunction with family-centred care practices to enhance the quality of care for patients, their families, and the well-being of healthcare professionals. This resource can be found in the Healthcare Toolbox website. It's a fantastic resource focused on paediatric medical trauma, helping children and families cope with illness and injury. I've shared a lot of links and resources in this presentation, but if you do nothing else, please go explore this website and come back to our knowledge translation session next month and share your learning or thoughts with us. And one final recommendation to all the paediatric health professionals out there listening. Vicarious trauma is highly relevant for those working with parent carers of disabled children. Alongside focusing on the well-being of parent carers, we also need to ensure our well-being. If we aren't well, how can we show up and provide the support they need? A few years ago, I was part of a study by Dr. Jackie Barfoot and Dr. Koa Whittingham from Australia, exploring paediatric therapist well-being using a pre and post survey following a package of online training modules specifically focused on the well-being of paediatric clinicians. The modules were fantastic and explored burnout, workplace stress, vicarious trauma, and provided positive coping strategies such as resilience, self-awareness, growth mindset, and mindfulness. I reached out to Jackie and they are currently updating this training and plan to relaunch it again this year. I highly recommend this, so keep an eye out on their website. Thanks for listening. Huge thanks to the Born at Right Time team for letting me share some of their work with you, and I highly recommend you consider taking their course. I hope to see you back next month in our knowledge translation session. The knowledge translation session isn't recorded and we run it as an informal, non-teaching session focused on open discussion, exploring how you might have implemented anything you've learnt here into your work. And to get you thinking, here are a couple of questions to ponder over next month. So, in your workplace, what service processes contribute to the ongoing small t trauma for parents? What changes could you make or advocate for to reduce unnecessary service trauma? What have you done or think you need to do to support your well-being to manage the impact of vicarious trauma on you? And make a commitment to spend at least 30 minutes exploring the Healthcare Toolbox website. And when you come back to our knowledge translation session, maybe share with us, what was your aha learning? What did you share or discuss with a colleague or manager? And what have you tried to implement in your work with children and their parent carers? So please click on this QR code if you've got any ideas that you want to share back with us or you want to join our mailing list. And just a reminder, the knowledge translation session is on March the 11th at 12 o'clock. I've already gone through all of those questions with you. So thank you for joining us. And I'd just like to finish with a karakia. Unuhia, unuhia, unuhia ki te uru tapanui. Kia wātea, kia mama te nāko, te tinana, te wairua, e te ara tangata. Koia rā e rongo, whakairea ake ki runga. Kia tina, tina, huie, taikie. Thank you for joining us.
Thank you, Jane. Really appreciate it.
Welcome.